was significant for them. They have a largely, they do a lot of charity care there, so they perform a lot of their patients, they don't get reimbursed for them. And that was between $300 and $400 million in cost for them, so it was significant. In addition, where they're based, there's a hugely growing population, and so they really just didn't have enough beds to keep up with the demand here. And lastly, the third point was around the CMS penalties. And you know, most people think that that is the primary driver for focus on readmissions. And whilst it's important, in the case of Seton, it wasn't actually the most significant thing. So what we did was we started this investigation, this project with them. And we had a workable model deployed there within about 8 weeks. And this revealed some quite surprising findings, right? So it was quite surprising to the clinical community at Seton what they found. And this chart kind of summarizes that in 3 areas. But let me start with this table here. What the table shows is some of the key predictors. So they came to us and said, you know, we want you to build a model using these predictors. These are the things that are going to predict readmissions for cardiac patients, right? And there were a list of 113 or so that we started with. That list grew to over 300 during the initiative. But the point was they found new ones, right? So the ones that they had identified as being the key, most important predictors for readmission, that was not borne out by the data. There were new ones, or those were not actually significant. So things like the ejection fraction, whilst it's significant for the disease, it's not a significant predictor for whether a patient is going to be readmitted. So there are all sorts of findings like that. If you look at the center column, that shows the amount of encounters where that measure, if you like, in the row was available in the structured data, so from their EMR. So looking at the ejection fraction, only 2% of the records in the EMR actually had that data point identified and actually recorded. And so and there were many reasons for that. The process wasn't being followed properly and various other things. But this was a real problem. And you can't really build a model, a predictive model, where you only have 2% of the data available, right? A model there will just not work. But when we looked at the unstructured data, the right-hand column here, we found that we could extract using NLP, natural language processing technology, which is the same base technology that's used in the IBM Watson platform. We found that we could greatly increase the availability of this information and also its accuracy as well. Right, so if you look at this, we went from 2% to 74%, and that's just through processing text documents, so whether it's a discharge note or a fax or other forms of unstructured data. And what we can do is extract those key terms and those key diagnoses and other measures from the data and use them to build and improve the effectiveness of these models. And if you look at something like the smoking indicator, that was available 35% of the time, but of course it's just a box, and so it's not necessarily updated, so it doesn't follow the progression of the patient. And there was a huge level of inaccuracy in that particular field, so 65% inaccurate. And if you think about something like smoking, if you find something written in the note that says, the patient cut back to 2 packs per day, everyone in the room knows that means that patient is a smoker. But you need the kind of natural language processing technology to infer that and to do that. And so what we did as part of the Watson project and at Seton is we built a series of these, what we call annotators, which combine this kind of logic and the rules, if you like, that extract these clinical terms and the meanings and the measures from the unstructured data. Okay? And so the end result was an extremely robust model that greatly improved the ability to predict which patients were at high risk from being readmitted. Now this chart is, you might not be able to read some of this from back there, but this chart depicts the top indicators for readmissions with their data. And so a couple of key points here. The actual most significant indicator, the venous distension, was not flagged as an indicator by the clinical team. It was not. Everyone, and I always get this question, and apparently every physician at medical school is taught that this is, but they weren't following the process and they didn't understand that. And so this just popped right out of their data. So not only was it unknown and not incorporated into their process, but it's also extremely easy to do something about, right? One of the problems with trying to apply analytics in healthcare is a lot of times you can't do anything about it. So if you identify that, say right at the bottom there, that heart attack history is a significant predictor, there's not a lot you can actually do about it to affect your process. Whereas something like this, as observed by the photograph, it's extremely easy to adapt the process and to prevent that patient, has that obvious visual problem from being discharged. And so it's extremely easy to do something about that. And some other indicators as well are natural candidates for care and intervention plans. Right, so again, if we flag these patients as having high risk for these particular indicators, like low sodium, for example, that's something that we can directly address in a care plan. And so those indicators that come out of the data that way are more actionable, right? And so they're the ones that make a difference, and they're the ones that that had the biggest impact at Seton. And just finishing up on this story, just to make one more point around the obvious benefits of doing this. So patient X, what happened to patient X was this was a sample from the data. The patient was hospitalized 6 times in an 8-month period for the same problem. And following the analysis, the information that would have predicted that patient as being at risk was available, at the second visit within sort of 30 days. So that information was there throughout this 8-month period, or for 7 months of the 8-month period. But it was unhidden. It was hidden in the data. And if you perform a basic back of the napkin cost calculation on potentially avoiding these types of readmits, not only in penalties but in the direct cost or the unreimbursed cost, as it's Seton, these are significant numbers. So just making a small change in the ability to predict and then prevent readmissions by putting these patients into the right care plan. And patient X was actually was self-abusing. That was the problem with patient X. That so the lack of emotional support indicators, the patient was self-medicating. And that was actually the problem with patient X. And these are all the things that we can actually change and influence through care management programs. So any questions so far at this point? Everyone enjoying their... yes, quick question.
You had said that the information that there was jugular venous distension was available, but they weren't acting on it? Or is that they were recording that the problem was there, but they didn't sort of do anything about it?
Yeah, it wasn't identified as an indicator for a readmission. So on a discharge summary, there was no process step to check for that, and perhaps not discharge that patient if they had presented with that specific symptom.
It was present, though it was documented as an observation.
Yeah, but it wasn't recognized as being a significant predictor, yeah. And some of the other ones that were considered to be the no-brainers actually were not significant. Sure, they're significant predictors of having the condition, but not necessary for being a readmit. And this is the thing, when we do more and more of these projects, the importance of combining the clinical guidelines and the knowledge-based evidence with this data-driven evidence is really striking in terms of how it changes based on different patient populations. And that's the type of kind of insight and increased accuracy, right, that we can derive from this type of data. Yes, question?
So we have a problem, kind of generally speaking, which is that everybody thinks they're unique and have to start from scratch every time. And this, to me, is a great example of a situation where it's highly likely this kind of problem exists.
Yes.
80%, 70%, 60% of the health systems in the country. The problem is that we wait for IBM to sequentially go through the
Yes.
in terms of any actual impact.
Yes.
So how does IBM as a company, and how does IBM senior policy people think about going to the players who matter to actually change this?
Yes.
And figuring out ways to actually accelerate it, and to what extent would you get behind sharing some of this information and maybe offering some ability to test it that would accelerate the process?
Yes.
As well?
Thank you for asking that question. Absolutely, that is our goal. If this technology is only, if it's too expensive for a regular provider to afford, or if it's too complex, or whatever other reason, it won't realize its benefits, right? And so there is absolutely a senior committee that are looking at doing that exact thing about how do we get this into the healthcare ecosystem, and not just North America, globally as well. And so there are a lot of conversations and dialogues going on with that. Part of it is, policy and political. But so at IBM, apart from technology and analytics people like myself, IBM has about 50 physicians that are working on this specific initiative at various research centers dotted throughout the world. We also have an IBM colleague, Dr. Paul Grundy, is central in the whole patient-centered medical home movement, and we have another avenue through contact with the government, for example, through various IBMers that are working on these actual initiatives. And so that's the kind of framework. But what I will say is, when we get onto the next section of the presentation, we are working on different models for this. The technology is extremely powerful, but it can be expensive, right, and complex. And so one of our goals is to figure out a way to make this deployable in the clinic. And we are literally really thinking out of the box here. And I can't share with you a lot of specifics today, but we are absolutely focused on doing that as a goal. And like, I just can't even, I'd love to just tell you this, but we were having a debate about this earlier on a conference call. And because IBM is we're not a healthcare company per se. So we are looking at partnering with healthcare providers and payers and whoever else to get this technology in the market. So that you'll hear a lot about this over the next 6 months or so. I can't divulge any of the detail, but we are absolutely focused on doing that. Yeah. Yes, and that's part of the conversation. Absolutely. Thank you. Thank you for that question. Yes.
You can just talk briefly about your starting point for your analysis of your unstructured data. Was it text fields in the EHR, or was it written documents used in natural language processing?
Yes.
Were they converted from text to natural language processing for local terms?
Yes. So the answer is all of the above. When I get onto a slide in a second, actually, I'll walk through that. If I could just pause for a second. But if I gloss over your question, please stop me again. But I think I'm going to address that in a second. Around the answer is all forms of unstructured information, and part of the platform is designed to actually do that. Whether it is a paper fax, we're always going to struggle, obviously, with handwriting. I mean, that's just a big problem. But certainly narrative, in speech-to-text technology is extremely robust and well-developed, as everyone knows. But that whole process and the framework of how we do that. And here's the key thing, how we do that automatically. So if a consultation fax comes in, how do we automatically get that information into the patient record? So that's the type of thing that we're looking at. People don't have to go and look for it. It actually pops up in the patient record. I'll cover that in a second. So where we are today, we're just starting to talk about the importance of unstructured data. If you just look at predictive analytics in any field, not healthcare, but any field whatsoever where this technology is used, it always improves the accuracy of the model. There aren't really any instances, and I've looked for them, where it doesn't fail to add to the accuracy of a model. And you saw it in the example of Seton Healthcare. it's significant. Some customers that we work with who have extremely clean data, you may not get so much of a benefit, but for the average healthcare provider, adding the observational data, a lot of it in unstructured fields, significantly adds to the accuracy of these models. And just to re-emphasize the point, the model at Seton would not work without the unstructured data. That model would fail to add value in their process without the unstructured data. The care guidelines, and thank you everyone in the room for not getting me into a rat hole debating clinical versus observational evidence, because I've spent an hour on that before. But just to say that, you know, we've proven that this can significantly enhance care, and it's not replacing a physician's knowledge. That will obviously always override. It's augmenting it. And this chart here, and what we can do is share, when we do, if we have a follow-up communication, I can share with you some of the research evidence that is the basis for this platform. In this chart that you see here was a part of a study that we did with one of the leading AMCs, and this is all published research. And the tiny chart, really what it says is that adding the data-driven insights or the observational data significantly improves the ability to predict cardiac disease onset extremely early in the process. Not Framingham 10 years, but 6 months. And that's a real advantage for putting those patients in the right care plans. So it's all of everything I'm talking about here is not some IT guys at IBM thought of this. It's all based on clinical evidence. And then workflow, we're not really going to have a deep dive here today on the workflow, but the care management process, you know, is extremely complex, and it's very difficult using conventional, traditional technology to map out a care plan. And so we've done a lot of work around optimizing care plans using analytics and applying those care plans in a tool that takes into account the complexity and the uncertainty of a real-life clinical care plan as well. So that's a big part of this. We're not going to have a deep dive on that today, but I just wanted to mention that here on this slide. Okay. So our solution is called Patient Care and Insights, and it was launched about six to 8 weeks ago or so at our conference. And it's really a combination of things. So if you look at the blue items here, content and predictive analytics, what this is a product that does the unstructured text processing. And so it's actually a platform, and it's used extensively throughout the industry and throughout all industries. And it does things like it will automatically detect that a fax has come in, for example. It will automatically run an algorithm that will extract the relevant information from the fax and then post it into a longitudinal patient record. It covers everything from Word documents, every kind of form of unstructured information, including paper and including voice as well, is all built into that platform. For healthcare, what we've done is built some specific annotators that are unique to healthcare. So my example earlier when I was referring to a patient who had cut back to 2 packs a day, for example. So in order to identify that as an indicator of smoking, we've built some rules around that and built those into this application. So for various disease and therapy areas, we can extract the right information using all the medical terminology. And that's also, interestingly, that's also this platform. The actual text processing is running on an open source platform called UEMA for Unstructured Information Management Architecture, and that's as part of the Apache platform for those in IT. And that is the exact same technology that supports Watson. Watson is built on the UEMA framework as well. And so our goal here is to, over time, and you'll see this on the next slide, is to incorporate the Watson Q&A capability into this platform, into this system. And that's something we're particularly excited about. The next thing, similarity analytics. This is new. I mean, I didn't mention predictive analytics there, sorry. That's a capability as well. Similarity analytics is new. It's a new way of basically extracting meaningful information from patient records, considering an extremely large number of variables. So say 30,000 possible variables or conditions related to a specific patient over time. Similarity analytics is a way of deriving a measure for that specific patient mathematically, and then what we can do is build a dynamic cohort based off that patient. And I'll have a slide in a minute, but this is new. This is a new capability that comes out of IBM research. And again, this is the subject of a few, probably 5 or 6, I think, research papers, which is published public research. And similarity analytics is the thing that lets us factor in comorbidities, right? Everyone's aware of this issue that we don't have a standard patient. A lot of the care guidelines, clinical trials are all assuming a single disease, a 65-year-old male, you know, with angina, whatever. And that's the basis for the care guideline. Similarity analytics lets us consider real patients with comorbidities. And it finds similar patients in our data and then lets us predict what's likely to happen to our patient because we know what's happened to this cloud of similar patients. So that's a key concept. Similarity analytics is built into this platform. And then the care management side as well. I've already mentioned I'm not going to dwell on care management in any detail here today, but one of the traditional barriers around applying analytics in any business has been around the acting piece, right? There's 3 components to predictive analytics. There's capture, getting the data. There's decide, which is the model, the predictive model. And then there's act, which is then doing something about it. And historically, the act piece is really broken down, particularly in a complex system like healthcare. Taking those insights and then putting those into the clinic have been a barrier, and they often end up as research papers. So one of our goals here has been to connect the predict with the act, and we do that through a product here called Care Manager. Right. So this is my architecture slide, which has a little build on it here. So this platform has two foundational components. The first part is really, think of it as all the analytics. So this is called Advanced Care Insights, and it combines content analytics, and this is where we get into extracting the unstructured data from text, from whether it's in electronic form in a document, or whether it's in a discharge note, or whether it's actually a text field within the EMR, extracting the information and extracting the meaning from that information and tying it to the patient record. That's the content analytics piece. The next section there, NLP and LPR. NLP, natural language processing. This comes with a set of accelerators specifically designed to process the text rules for healthcare data. So that's really what that is, and there are several of those. LPR is a longitudinal patient record. We're not in the EMR business here, so we're not suggesting that this replaces an EMR platform at all. What we're saying is it layers over the top. One of the key requirements for these predictive models is to look at the observational data over a period of time with the patient. So the only way we can do that is to create these virtual longitudinal patient records within the system. So it's not replacing an actual EMR platform in this capability. It's designed to get the information in a usable format for the analytics models in the care management platform, right? So we're not in the EMR business. Predictive analytics is a core capability, and we use various techniques and capabilities that are not necessarily new here, but it's really the way we've tied them together that is. And then the similarity analytics, which, as I've described, is a new innovation from IBM Research, and that is also built into this platform. I have a little diagram explaining this in a second. The care management piece is integrated. So the basic idea here is we will predict from the population of patients which patients are at risk for which conditions, and then put those patients into a care plan. So it's a way of identifying at-risk patients, whether it's from the population or whether it's for a specific patient in response to a specific event, right? And so the idea is that the at-risk patients flow into the care management system. Okay. And I'll show you a little bit about the visualizations in a second, but this has been another challenge in healthcare, is visualizing the data. You know, if we're trying to look at, you know, what is likely to happen to our patient, for example, you can't really understand that from looking at a bar chart, for example, or a pie chart. And so as part of this innovation, we've created some new visualizations, and I'll show you one of those in a second. But again, this is cutting-edge techniques and technology right out of IBM research. We talked about the unstructured information already. Watson is a key component of this for the future. So the way we work with Watson today is it's as a placeholder, right, today. But that is absolutely something that is going to be a priority for us next year, is integrating Watson. I'm assuming everyone knows about IBM Watson here. So I assume everyone saw the Jeopardy game and that type of thing. And Watson's first industry is healthcare. And Watson's at medical school. It's cheesy, I know, but Watson's being taught at the Cleveland Clinic, right, how to do diagnosis and support. Watson's learning all about oncology at Memorial Sloan Kettering and MD Anderson. So there's an awful lot of initiatives and work going on trying to incorporate the Watson technology. And at its base level, it's going to help with decision support. So when a patient comes in for a diagnosis, Watson can query not only the vast compendium of medical knowledge and information that's out there, all the guidelines, combine that with the actual unique patient data from the patient record, and then come up with a ranked series of possible, possible diagnosis or suggest the right treatment plan for that patient. And again, it's not saying, this is what you need to do. So we're not taking the doctor out of the loop here at all. It's just providing support in an evidence-based way. So it doesn't say, this patient has, malaria. It will say, based on what I know and what you've told me so far, the probability that the patient has malaria is 73%. So, and it will then even suggest additional diagnosis steps to confirm that diagnosis. So it's not replacing anyone here, it's augmenting the physician, right? And then the infrastructure, and this is where we can potentially get into another rat hole here, talking about the infrastructure. Yes, of course we know that healthcare data environments are extremely complex, and even with new enterprise rollouts of EMRs, there's still a lot of, some of our customers have 75 different EMRs in their environment, for example. And so, yes, of course, it's a nightmare, and we know that. But we do have various technology and model components that can at least help with that. And the way we approach this, in some cases, is to say we're not going to boil the ocean. Let's go after a specific problem and then figure out the data we need to solve that problem, and not try and solve all the problems in one go, because otherwise we have a 10-year never-ending IT project, right? So there's all sorts of ways around that, but in no way am I belittling the challenge around the data. So let's just talk briefly about similarity analytics. This is the point I was making earlier. I'll just expand on this around clinical trials and care guidelines focusing on a specific patient. Many patients don't fit those profiles, and there's some statistics there around 25% of Medicaid patients have at least 5 comorbidities, and Medicare patients with 5 or more chronic conditions accounted for 76% of the expenditure. So the typical patient that you're seeing in the clinic is not the standard patient, and all the treatment guidelines are based on that. So what we have is for this patient. So what we want to do is try and analyze all the longitudinal data for that patient across a huge amount of interactions, encounters, prescriptions, whatever's happened to that patient over a period of time. We suck in all of that data, up to 30,000 possible columns of data. So think of an Excel spreadsheet with 30,000 columns. That's our model. And then what we do is we basically calculate a series of risk factors from that data and condense that into individual risk factors, or what we call metrics, right? So we're basically defining a patient with comorbidities mathematically. And then what we can do is understand the risk profiles for specific conditions for that patient, And then what we do is we apply those. When we've defined our patient, we have this thing called a dynamic cohort. So we'll go out into the data model and pull in the most similar patients based on that mathematical calculation, right? And because we know the history of that dynamic cohort, we can then predict what is likely to happen to that specific patient. And this has a number of applications. Not only does it greatly increase the accuracy of these predictions, but it enables much more realistic and usable care insights. So, for example, our cardiac disease onset case study, for example, we're able to predict with a window of 6 to 24 months whether a patient is at high risk of CHF onset, for example, in a far more accurate and robust and usable way, right? And so this is the progression of cardiac disease. And if we can identify the at-risk patients early, we can put them in a prevention plan early on and really change things. This is an example of a patient that's pulled up into the system. So the system here is Judy Smith. She's had an event's happened to her. It could be a new diagnosis or something like that, or an observation that's triggered this risk identifier. So she may be a diabetes patient who hasn't previously indicated symptoms or hasn't been at risk or of concern to me if I was a care manager or a primary care physician. And so something new happens and the system can identify that. And so she gets flagged as being a high risk. And then the dynamic cohort works and it pulls up this visualization. And how this works is, if you look down the center there, sort of number 3, that's kind of where we are now. And the different colored bars represent previous conditions or developments. So whether a patient has diabetes. And the relative height of the bars represents, for this cohort of patients that we've identified that are similar to Judy, this is what happened to them, right? And we can predict, basically, the idea is the red is bad, right? So when we click on the red bar, it shows us the number of patients, and we can see what led to those, the evolution of those conditions. And basically then try and think of the interventions that are most likely to, at least statistically, keep Judy off the red path, right? And so this is a new technology called patient outflow, and it's part of this solution, and it works very nicely with similarity analytics. So right there, I can see for this particular patient, based on the dynamic cohort, what happened to those similar patients. And I don't know about everyone in the room here, but I certainly would like my physician using this when they see me. The other thing we can do with similarity analytics is look at treatment optimization. So, for example, for that particular patient, for a group of similar patients that are prescribed a statin, and here are the 3 bar charts here, lovastatin, atorvastatin, and niacin. This will predict for that specific patient which of those medications has resulted in the lowest cholesterol level. And that's based on that specific patient and a similar cohort, not based on our standard patient. Right? And the idea here is then that we can make a treatment option here and make an order and make a prescription decision right here, and that will update the care plan. Other things that this lets us do is find the right physician. And again, this is not supposed to be ranking physicians, but there's an awful problem with complex comorbidities around finding the best physician to treat that specific patient. So what this tool does is it looks at, for each physician on the list, which physician has had the best outcome and the best history for patients like me, right, for patients like that. And again, this is a useful tool, particularly for extremely complex and difficult to treat patients. Let's try and find in the system or in my health system which might be the best physicians to assign here, rather than do it based on sort of gut feel. Another aspect of this, and again, I'm sorry if the contrast here is not great, but you can all get hold of these slides. This is around identifying abnormal utilization patterns. So, for example, if I have an age, so say Judy Smith here is 52, she is overutilizing the ER, for example. But if I look down this chart, you'll find that she's underutilizing outpatient visits or PCP visits. So this is a way of identifying, again, maybe why isn't she visiting her primary care physician more often, for example? So to systematically identify patients that are exhibiting abnormal utilization. And it's not just, let's try and find the most costly patients and dump them. In some cases, a patient may be, underutilizing the resource, and that's more of a problem than a patient that's overutilizing. So this is another tool that flows out of that core capability. So I'm at the end of the slides here, and I just feel that feels like I've been talking for hours. I know I had a few good questions in the middle there, but if anyone has any more questions for me right now, or we can do follow-ups or anything you guys would like, we can do that. And of course, if anyone wants more information, we can absolutely provide that. Yes, question.
So, let me say this isn't fully unfair and unreasonable question.
Oh, right. Is that the? Please go ahead.
So, you don't have to go into detail about the data sources.
Right.
I think it's that's an interesting question in its own right. It's how you get to critical mass by disease, by type, by whatever. You're going to go with that. But it seems like after you've done this for a few diseases and a few healthcare centers, it might actually be possible to do similarity analytics across health systems.
Yes.
Which would then enable you to actually predict who could create the most value out of applying this. Is that something that...
Absolutely. Yeah. All of the research that supports these models and this approach has all been within an individual health system. Some of them are extremely large, but within an individual health system. And absolutely, if we could get access to a bigger population-sized data set, that is occurring internationally, right? So we're having conversations, abroad at Singapore and in Denmark, for example, about doing that. But particularly within North America, one concept we have is around, creating like best practices models and then making those available as part of this package. And we're doing that today with some aspects of this. So, for example, the text extractors that I was describing, we already have those, and that's part of this. So you can leverage, or other healthcare providers can leverage the insights and the research that we've done already, figuring out how to create these measures to predict CHF. We've got all of that. But I agree completely with you that the real future of this is around incorporating these insights into everyone's data and trying to do that and sharing it. So why, like, if I'm, Westchester Medical Center, why do I need to go through this entire process and build these models and figure out what all the predictors are? And why can't I use someone else's model, right? And that's exactly one of our goals. It's not available today, but that's exactly something we're working towards.
And I'm thinking of even one step more in
Yeah.
which is, could you actually get to the point where you can use the publicly available data on the health system?
Right.
Correlate with, you have connections between real data and health system data on the people you're working with. On the other side of the equation, you just have the health system publicly available data. But theoretically, that would line up in a way that would give you enough information to say, this is a really, big opportunity to say, this is medium, this is small. It would be hugely accurate, but then you could analyze everything.
Yes, I couldn't agree more. There is an argument to say that, so the cardiac onset model that I described here, that's based on 50,000 patients, 7 years worth of longitudinal data. So that's quite a lot of data, and 3 million encounter notes, something like that. But that is, there is an argument to say if you added another 50,000 patients, would it improve actually the model? And that model is already extremely accurate. So there's an argument to say that we don't necessarily need to do that to a large degree. We can get the accuracy with less data, but absolutely in principle, opening this platform up to bigger data sets is absolutely, and cross health system data. And I didn't mention this earlier, but several of these models can also incorporate claims data, right? So we're not looking at just clinical data here. We're also utilizing claims data and, of course, demographics as well here. I didn't make that point earlier, but I couldn't agree more. Like I said, we are all the happiest people alive here at IBM on this team, because we can really see, how this can change things. And it's not just a IT geek's vision of it. This really is a transformative technology, we believe. Okay, questions?
I see you mentioned the LPR, or the longitudinal paper
Yes.
record. I imagine that's sort of like the computers taking the unstructured kind of health providers' data and structuring it. Is it?
Exactly right. It's represented as what we call a universal feature model, and it basically contains the longitudinal data. It's not the full data set. It's what we need for the model, and that's interestingly how it works, because if you try to run one of these models against a regular EMR with all the unstructured data, the predictive model would not. It would not scale. You would need a room full of supercomputers to run the model. So this is a way of compacting the data, if you want. So the LPR is a virtual model. It sits over the EMR, and it's optimized for the analysis. Absolutely. And the other thing, and combining the structured data, because there is some structured data here, right? It's not all structured. I didn't mean to give you that impression. Some of the models that I described are all structured. Some of them are 50-50, and some are depending on the individual customer and the individual hospital. But we need to combine those, and our LPR is a way of doing that, and it retains the semantic relationships and that type of thing.
And then it sort of draws in the 30,000 variables that you
Yes.
want.
Yes.
Just those.
Well, it's not. We don't end up with 30,000 in the model. There's two steps. There's the train step, so we train the model on the data. That's where that's where we're doing data mining. So we're looking at these 30,000 variables, and we're figuring out which ones are meaningful for which particular condition. So there's a lot of these, and then we extract the meaningful number of measures. We don't use all 30,000 for the actual model that's deployed. We use which are the significant predictors, and that can be a few hundred. Excuse me, it could be 500, but it's certainly not 30,000. And that's the thing that's deployed to score the individual patients and goes out and creates that dynamic cohort. But we do need the base platform to be able to cope with the extremely large amounts of data, yes. And that's one way, and just going back to the other question around scaling this up. Of course, one way we're looking at this is as a service, right? That's important, because not every Westchester Medical Center, sorry for keep using that as an example, but they're not going to go and buy Watson, are they? So we need a way to deploy these in a cost-effective way. And so, yes, of course, we have a cloud strategy for this as well. And I probably opened up another rat hole here because around PHI, right? So that's obviously a big concern for us. And again, IBM doesn't necessarily want to become the custodian of PHI, right? But there are all sorts of ways around that we're figuring out the right approach here. But yes, a sort of cloud or hosted model is on the cards, yes. All right. Question. Now, this is going to be the really bad question. This is going to be the... yeah. Yes. See? Oh, yeah. Absolutely. Absolutely. Let me just show you this. It's too small for you to see in clarity, but we can share this with you. So when we went back to Seton, that was one of their drivers, was around the cost. I'm sort of making everyone dizzy here. Yeah, right here. You can't actually see it, but this is a dashboard right here that actually is predicting the cost. So for each particular type of patient, in each group of patient over time, it's predicting the cost of readmissions from those different aspects, whether it's a CMS penalty or whether it's the actual direct cost or unreimbursed cost. So that's extremely important, and that's also a feature of the model, yeah. And the same thing on when we were discussing similarity analytics, the treatment utilization as well, that also is used to predict costs as well, right? Okay. Great, thank you. Well, I've enjoyed myself tremendously here. I'm really starving, but thank you so much, everyone, for showing up. And I have cards, and we'd love to have a follow-on dialogue with anyone in the room. Like I said, I'll just end where I started, and just we have the best jobs at IBM here doing this, and we're just so enthralled by what this technology can do, and it's fantastic. Thank you very much, everyone. Thank you.